we started with MRI, so I'd like to proceed with that MRI and start the discussion about the European consensus on imaging in prostate cancer, and I'd like uh, to find Dr. Arturas Suvashovas from Klaipėda. Hello, Arturas. He is also very experienced in MRI, and Ieva Naruševičiūtė come together, and we will start this session. Maybe a little bit closer. Yes. To see. Ruta, come to me. Yeah, to see. Hello, Arturas.
Hello, guys.
So I'd like to share my screen and to see the slides of. Oh, what's my mouse? That's my mouse. Yes. Now that's there is an European consensus on imaging in prostate cancer, so I'd like to discuss this. And that was a study, this consensus on this Delphi study on multiparametric MRI for the detection of clinically significant prostate cancer, and there was 44 expert radiologists and urologists in the field of prostate cancer that did some consensuses in prostate imaging, and we'd like to highlight some parts of this consensus. And as you see, one of the main thing, as Ruta also said, that we need to participate in multidisciplinary teams meetings, and all the radiologists that work in this field in prostate cancer, prostate imaging, also must attend these tumor boards, because we need the feedback from not only look at the images and to see what's going on with these images. And as you see, this was 98% agreed with this. How is in your clinic, Arturas?
In our clinic, we are Center for MRI Excellence, and we are trying to work in like expert centers to do what we can do the best for diagnosis. In our center, we are working together with urologists, with pathologists, together with radiotherapists and oncologists. We have MDT meetings. It's times planned scheduled at advance, but in we have not so many people from radiologists working with MRI exams. It's enough specialist exams and working just a couple of people working with it, and we have workload. We supervising all exams do other radiologists. Me on this field working, me and two radiologists. Two more and all exams we can see together. So we think it's better for growing doctors' competency. It's growing faster, and of course it's less possibility for mistake when the same exam looking for two people, not one.
Mm-hmm. Yes. So actually, National Cancer Institute, we also try to attend all the multidisciplinary team meetings. Yes. Yeah. And to discuss the results of our reports with urologists. Of course, as you see that a multidisciplinary team, there must be an urologist, radiologist, pathologist, medical and radiation oncologist. So actually in our teams we have all these specialists. The consensus is not 100% reached, but still 86% agree with that. Actually, sometimes we have some problems because pathologists they are not always attending these meetings, and I think it should be that pathologists would attend always. So that will be the drawback in our institution. But the others usually they are attending. So what about the prostate targeted biopsies? As you see, prostate radiologists should have a role in shared decision on making targeted biopsies. In our institution, we always have a tumor board for the biopsies. We discuss all the cases. If we need some special biopsy, or maybe we need only transrectal ultrasound guided biopsy just because of the big tumor. So any biopsy could reach that lesion. Sometimes the lesions are very small, and only in-bore biopsy could help us to find the clinically significant cancer. So the agreement is quite big in this consensus, and yeah, some any remarks on that?
Maybe if Arturas, maybe you have some points about reading cases of radiologists. What can you say about it? The consensus said that beginning radiologists should read 400 cases, and for experienced one, it's 1,000 cases. How is it possible for a radiologist, for example, working in Klaipėda? Is it possible to have such amount of?
Of course. For example, in our center, we do about 700 to 800 cases per year. So working three radiologists have enough cases for basic and more for advanced. If we looking all cases, they see. Yes, it's share, it's experience. So it's enough big numbers. But what I want to say, in other centers, we have problems within Lithuania when in other hospitals no dedicated radiologists working with these exams, and it's spares these exams between all radiologists, and they impossible to get this number, to get even basic level of knowledge to correct evaluate these examinations. In our institution, of course, it's not problem with numbers, and we are planning growing up this number because we have big demand to do more these exams. And I think not only we, all radiologists, all departments will feel it, because this, maybe we talk later about changing guidelines. It's necessary to do more MRI exams for prostate.
So, but in this field, we see that it's not so easy to be an expert in this field. You have to make a lot of cases, a lot of reports on MRI, and actually not every center may be an experienced center according to these conclusions, or according to this consensus. So actually, the rate is very high to be an expert, or even a beginning radiologist should have 400 cases. So maybe yes, it's possible sometimes
if we
get
have
this.
screening,
Well,
then
you are looking very pessimistically. I think it's not so bad. If, of course, what we need, what is in Sofia, it's organization. If department organizes its job and concentrates these exams to dedicated radiologists, it's possible for all big hospitals, for example, in Lithuania, like our Republican hospitals levels, it's possible to get enough cases for 1 or 2 people get at least basic level, and to have one maybe in center man with expert radiologist in 3 or 4 years to growing up expert radiologist. It's possible. In big hospital, it's real possible because hospital which have urologic department, they have enough cases, prostate MRI cases. It's just organization. I think it's problem organization because they can get concentrate this exam to dedicated people. It's fair to radiology department, and this numbers of experience is very low and not enough. It's my opinion. I think so. And what we can see in our hospital, it was possible to do this right ways, and of course dedicated courses. If we have dedicated people working with prostate, we can get special courses to them. It's possible enough fast growing up, and in our experience, we have our doctor, for example, starting working with prostate in 2 years, she get enough competition to be basic radiologist to get 400 cases and enough theoretical and practical knowledge just to do this exam, right? Of course, it's our some centers in Lithuania we have big experience. It's our job help other centers growing up, help them to do maybe courses, maybe some support or supervising. It's very important. Of course, it's our job too. I see your center, one of the real center with prostate center who can do it, and how can in our possibilities we do the same in our region.
Yeah. So maybe these you see there are some double reads. Some centers maybe
Yes.
double reading. Of course, when you do double reading, you can make more cases per person, per specialist, and actually in that way we can make the experience in that field. Of course, after when you have double reading, I think you can also get better experience because it's something like
it's much more faster.
So we can recommend this like our consensus to participants of our workshop.
Of course, the consensus on double reads it's not very high. It's 52 and 64% of the participants. Yeah, so maybe, but still, that could be the help for the radiologists to get more experience in that way. I'd like to say one more thing about the feedback. Maybe it's also very important to have the histopathological feedback. So National Cancer Institute and your hospital do the biopsies of the lesions in prostate, MRI guided biopsies. So I think it helps a lot to have good experience what you see, and when comparing with pathology results, you can really say that you saw the lesion that is clinically significant cancer or not. So as you see, it's the 100% agreement on that. So actually, how do you think the center should have the biopsy possibility to do the targeted biopsy?
Of course, it's no discussion. at least before targeted biopsy time, when we don't have this system, of course in Lithuania do only cognitive biopsy, yes, but of course we check this feedback. Result from TRUS biopsies is feedback too, and we have results from radical prostatectomies, from TRUS biopsies, and it was result. But when we start working with targeted biopsies, involved targeted biopsies, of course, it dramatically changed situation, and for radiologists, is value it's huge. Of course, you can growing up much more faster. You know, answer what lesion, what you suspect, what is histological answer in this region. It's very useful, and of course it's very helpful. Is it necessary? If for all hospital, maybe not to all hospital, but I think for hospitals who are centers for prostate cancer, who concentrate these exams, I think of course it's likely it would be very, very useful.
Yes. So our opinion is the same, I think. Yeah. So it's very important. Does anybody has any more comments on this slide? I think we discussed all the points of this consensus. So let's go further. That's the question about multiparametric and biparametric MRI. How do you think, Arturas?
Could recommend this.
Is it really for experts only?
Of course. Biparametric MRI is very attractive. It's of course we have now we have a problem with two sides. One side we feel a huge demand to do more exams, more, because we must do before first biopsy. It's patient active surveillance and so on and so on. And we have huge amounts of patients coming to us. Without to do biparametric MRI, we save time, we save money, we save patient from gadolinium injection. So it's looking very attractive. But its other side, it's a risk exam. Even on multiparametric MRI, we have a huge gap between quality of evaluation between radiologists. It depends on exam quality, it depends on the competence of radiologists, and so on. On biparametric MRI, its gap is much more. So it's risky exam. But what we have now, many trials in Europe in expert hand, this tool is effective. It's the same sensitive, the same specific like multiparametric MRI. And you can see in this in this slide, it's real for expertise, it's no significant difference, but it's very huge different if its expertise of radiologist is lower. So we have, with careful, I think we can use it. In our experience, we use biparametric MRI about 3 years. What it's helped us in the same time, we can grow up our exams about 40%. Of course, it was very effective tool, but for example, in our institution, all biparametric exam, it's checking by radiologist online. In case if we need, we of course do multiparametric, we change it to multiparametric MRI. We have strict criteria which patient can go to multiparametric MRI and which patient can do biparametric MRI, and we hope so the result is enough good. Of course, again, it's organization, it must be only in experience center. I think for today in our country, it's possibility to do maybe in your center and our center. We have many exams, so it's not recommended from us and not recommended from guidelines for today to do every day in every center. It's not recommended to routinely use for all. But I think it's a very perspective exam, and I believe it come to everyday use, for maybe for screening in future or so on.
Yeah.
What's your opinion? Thank you.
I have one question. How many patients you upgrade from from biparametric, when you do biparametric, how many?
From our decision, what our first filter for biparametric MRI, it's low risk patient. Yes, not operated, no high PSA, no digital rectal examination positive, no family history. It's like example, it's patient with elevated PSA, first time coming, and urologist, following by guidelines, urologist sent to MRI, not to biopsy. It's typical patient for biparametric MRI. In our practice, they upgrade by MRI result to multiparametric MRI about maybe 10 to 15% online.
So, but when we are talking about the screening, so I think biparametric is the very important thing in screening, because we need time. We need a lot of examinations to be done, and in this case we have, and of course the contrast is also a contrast. It may have some harm. So biparametric, it's also, if you see something not clear, if something is suspicious, then you can repeat the exam as diagnostic multiparametric imaging. But still, I think biparametric MRI will be the screen in the screening programs.
Of course, but not, I think, not screening. What we do now, following by European Urology Association guidelines, it's recommended to do MRI before first biopsy, for biopsy naive patient. What we do, it's screening. It's MRI, it's became screening tool for biopsy, for aggressive evaluation of this patient. Yes, it became screening now. Not for every patient, but if we talk about our PSA program, patient with elevated PSA, next step MRI. So it's become screening tool now. How we call it? So I think it's real tool, and we using, when it's using like screening, it is okay by biparametric. But not for detailed diagnosis. Of course, not talk about high-risk patient, and we don't talk about operated patient after treatment. Of course, no. Maybe in some cases, of course, inactive surveillance, sometimes we do. We go into biparametric exam. When we have known patient before, we have multiparametric exam before, and it's in follow-up. Of course, it's possible to use, I think, with biparametric too. In case when we have radiologist check online, if something is suspicious, we always can check to multiparametric MRI online. Or in case we can recall patient for contrast enhancement to do this second sequence, DSA sequence. It's this patient, this number not so big, so it's not trouble organizing repeat recall patient if we need.
And for less experienced radiologists, the contrast enhanced images, you recommend it or not? Because contrast can add more information, especially for less experienced radiologists.
Of course, what I talked before, biparametric MRI only in centers where working experienced expert level prostate radiologist only, because who can always check biparametric exams for quality and rule out missing or suspicious lesions, what can be hard for basic or less experienced radiologists.
Yeah. That's of course right. When you start reporting MRI, so start with multiparametric, but still, if as it's like in mammography, in screening mammography, non-expert radiologists, they don't do the mammogram screening. It should be also with the biparametric MRI, which goes for screening. Yes, it should be done, but only experienced radiologists should do that. Okay, so any comments about that? Oh, I can proceed further. Okay, so that's also about the biparametric MRI.
What we talked before, why biparametric MRI is attractive? Yes, what we can save on this? You can see last point. It's Cochrane meta-analysis. Yes, what we save when we use MRI like a screening tool, we can save biopsies. Yes, we found more significant cancers and less insignificant cancers. So all these points are very important to clinical practice, and I think, of course, its advantages are huge. What is minus disadvantages of this? Too many cases, too many exams for radiology department. Is they ready for this for this amount of patient? I'm not sure for today.
Yeah, that's an open question for.
Open question, yes. It's very detailed and working with urologists, working with clinicians, and with radiologists. We can work together, I think, in this.
Yes, of course. That's. The other question about the biopsy, as we know that standard protocols are 12 transrectal core biopsies. It's a standard for a patient who is with elevated PSA, but still we can miss up to 30% of significant prostate cancer because of the position of the cancer. Sometimes it's not reachable transrectally, and also we can overdiagnose that cancer that is insignificant, and we also overtreat these patients that could be not treated, and it depends. So that's still very important to use multiparametric or biparametric MRI to sort these patients that need biopsies, that do not need, maybe some need surveillance, and so on and so on. And as we all already discussed that in 2017, we found some high-level evidence that the use of multiparametric MRI is useful before prostate biopsy. It doesn't matter if it will be the standard blind biopsy or targeted biopsy, but we have a lot of information about these patients. How do you think about any ideas, any comments?
Well, of course, talking about this system, when we do MRI before biopsy, I think it's logical, and from a patient point of view, I agree absolutely with it. At least we have less biopsies. Yes, it's a positive aspect, but like radiologists, what we talked before, it's disadvantages of many patients and not ready radiological departments for this amount of patients. I don't know how in your institution, in our hospital, we have scheduled a list for prostate MRI a couple of months. It's very long time, and big pressure to do more exams.
Yeah,
and not often it's possible to do just prostate MRI. It's not ready for it.
Yes, so that's why I'm talking about this biparametric screening tool.
Yes, it's some help. How I say it, it's what we can do more in the same time. 40% more exams in the same time. So it's really big advantages.
So with this MRI targeted biopsies, actually we help people to find the really significant, clinically significant prostate cancer. As you see, it's in 93% sensitivity compared to 48% for trust-guided biopsies, and negative.
And I think maybe we have urologists in this discussion. What they can say, what the waiting list for the patients, maybe they could share their experience about MRI before biopsy, how they are doing with this, because the recommendations of ESUR, they say that there's not so strong indications for MRI before biopsy in naive patients.
Yeah, so these are recommendations, and I think we don't have any urologists participating in live discussion. So no, so these are radiology guys.
So we can put this question into some tests or something where we can find some feedback.
Yeah. So actually, the recommendations are from all European urological societies of prostate that deals with prostate cancer. Still, as you see, do not use multiparametric magnetic resonance imaging as initial screening tool. Yes, that's right. Maybe we need some high levels of PSA to do the multiparametric imaging of prostate, but that's a strong recommendation. Also, we need to adhere to PIRATS guidelines for acquisition. That was Ruta was talking about, that we have good quality imaging. It should be, even we have some it calls peak wall PIRATS quality guidelines to find out if the image is of good quality or not. But Ruta mentioned some clues of that, and also good interpretation according to PIRATS guidelines. And also we need, as we were discussing, that we need to tumor boards meetings to be attended to get good feedback of that. So these are strong recommendations. For biopsy naive patients, yes, again, we have that we need the MRI imaging before prostate biopsy, just to have also naive prostate, not to have any problems with interpretation of post biopsy things. When MRI is positive, it's more than or equal to 3. Combined targeted and systematic biopsy. I think that it's strong recommendation level, but still we can discuss about that, because sometimes if you clearly see the aggressive tumor, is it necessary to do the systematic biopsy? How do you think?
Of course, I agree with you. It's absolutely, you are right. Why to do more biopsy if you have diagnosed aggressive tumor? Because it's depend what you do after. Yes, if your treatment will be radical, it's not necessarily looking something more in this prostate.
To find
if we have right diagnosis.
Yeah, to find less significant cancers in other parts. So, of course, as you said, so we need some multidisciplinary approach before maybe doing the biopsies, as we discussed previously from this consensus, that you the radiologist should be in part of tumor board to decide if it's targeted biopsy or systematic biopsy is needed. So it's really clear. And so if we have the clinical suspicion of prostate cancer, but it's low and we don't see anything, so we can omit the biopsy. We can do the repeated MRI after some time, after 12 months or 6 months, I don't know, and not to do the biopsy. How do you think, Arturas?
I will talk about this problem later in my presentation. I have some slides about it, about two strategies, combined pathway and MRI pathway, and this problem is discussed in European Urology Association guidelines too. Yes, they not decision which pathway is correct, and I think future will stay in right sides with strategy is correct and more acceptable for patient. In my opinion, of course, systemic biopsy is very limited. It must be used in case when we have high suspicion of prostate cancer, but MRI is negative. Maybe we can think about invisible, so-called invisible MRI invisible cancer, and to do systemic biopsy. But if we have correct follow-up, I think we don't miss significant cancer if we don't see in MRI at first time. So systemic biopsy, it must be very thinking about when in real necessary. And for new days, I would like to ask you too, what is your experience of how many patients you see biopsy naive patient coming to MRI exam? In our center, it's number growing up very rapidly, and 2 years ago we have small numbers of the patient. Now we have up to half patient, primary patient coming to MRI is biopsy naive, and this number growing up. So I think it's showing what is the position of urologists to do primary biopsy, to do fast saturation biopsy at first. They are thinking to this side too, working together with MRI, and after MRI, like screening to results for choosing biopsy. When we have MRI, we have lesion. Of course, next question: why to do saturation biopsy when we can do targeted biopsy? So it's the next question.
Mm-hmm. Yeah, so in our hospital, in our center, we have a lot of primary MRIs for biopsy naive patients with PSA level higher than normal. And what is the proportion, as you said, in your clinic between those biopsy naive patients and with
the next patient after treatment, it's patient after biopsy? I think biopsy naive patient coming up to 40-50%.
40-50. I think in our center it's a little bit more than 50% is biopsy naive patients. So actually,
it became a rule. Patient coming after MRI became screening tool. What we talking about before?
Yes. Actually, that's in National Cancer Institute is the rule. Yeah. So, okay. So when after negative some kind biopsy, I think I'm not sure why the rating of that recommendation is weak when MRI is positive, and then just you always need to perform targeted biopsy only because before you didn't get any cancer. So I'm not sure about how do you think about that?
Of course.
Why it's weak? It should be strong, I think, especially in this
prior negative biopsy when MRI is positive. It's we think that it's could be indication for targeted biopsy. If previously it was systemic biopsy, for example, then of course, if it was targeted biopsy, we should maybe discuss with pathologists what was the reason. Yeah.
But still, that in our center is the rule to do if the MRI is positive for biopsy negative patients, so we do the targeted biopsies only. Okay, let's go further because the time is coming. Yeah, so some ideas about the guidance of the biopsies. So we can do cognitive guidance, we can do ultrasound MRI fusion guidance, or direct in-bore guidance. So I wanted to discuss when should we use different modalities. Any ideas of that?
I think in our country, of course, it's limited choosing. Time before we have only one possibility to do cognitive fusion biopsy, yes, and after some centers get some devices to do or in-bore biopsy like our hospital or fusion biopsy like your institution. And only now your institution have both modalities, or maybe you have all three possibilities to do all three types of targeted biopsy. And of course, will be your experience what is the best using. But by literature, we know it's not opposite one against other. They are different, but in many cases they overlap. Indication to do targeted biopsy, it's necessary. How do targeted biopsy, of course, depend on clinical situation and on patient and findings on MRI. Of course, very small lesion, very small, I think less than 1 centimeter, anterior part lesion, in any difficult place for biopsy in traditional way, lesion is candidate for in-bore biopsy. Cognitive fusion biopsies, it's possibility. A huge lesion more than 1.5 or 2 centimeters dorsal part, peripheral zone, it's possible cognitive fusion. All other lesions between them, I think it's possibility to do for fusion biopsy. So we can show very nice places where can do the best type of targeted biopsy, but in many cases they overlapping each other, and we can do no matter in which how we do targeted biopsy in many cases, my opinion. Thank you.
Yeah, and there is still some advantages and disadvantages of each modality.
Of course.
Yeah, there are some transrectal, some transperineal. So I would give the priority to transperineal biopsies because of the infection risk. It's more sterile to do the biopsies through transperineal approach. So that is with fusion ultrasound and MRI fusion biopsies. But there are some disadvantages because of, for example, in-bore guidance is only for 1 lesion, 2 lesions. You can't do the whole to look for some cancer extend to other parts, especially when you are thinking about the focal therapy. So it's more ultrasound and MRI fusion biopsy has more advantages against the others. But still, when you have very small cancer, very small lesion, sometimes you can miss it on fusion biopsy. So in-bore biopsy could help in this place. So in our experience, we still think that if you have big lesion, big tumor, so you can even do it without any guidance, just in blind biopsy you can find the cancer. But if the tumor is smaller, so if it's very small, as you said, less than 1 centimeter, less than half centimeter, about 6 millimeters, as we think that it could be the significant cancer. So in-bore biopsy could help us. But if it's bigger, so I think any biopsy can be of choice. Just you should think about the complications of each biopsy, the need of antibiotics for after the biopsy, and so on. So every biopsy has its own advantages and disadvantages, and if you have all the possibilities, it's easier to find the best result for the best choice for the patient.
Yes, can I say one word? I absolutely agree, Mantas, with you, and I think all centers who really working with prostate cancer, it's big advantages to have possibilities to do all types of biopsy, and in-bore and fusion. I think it's future to have both types of biopsy in one center, because they both can work better in some situation. So it's very nice when you can choose the best option for patient.
Okay, so and the last slide, that is the comparison of in-bore versus fusion MRI targeted biopsies. Maybe Ruta, you can comment some.
I'm not performing biopsies, but this study was interesting for me. About the preparation, when to perform in-bore. So the main conclusion was that in-bore may be preferred when targeted biopsy without systematical biopsy is considered appropriate. So what can you do in your experience? Maybe after targeted biopsy, you are not doing systemic biopsy. So maybe this could be some indicating for choosing this biopsy. If you are not going to perform systemic biopsy, then take it in-bore.
Arturas?
Sorry, I not understand question clear. What you?
Yeah, if it's just about for discussion for you, like those who in your clinic you perform mostly in-bore biopsies.
Of course. Yeah. We do systemic biopsy. Of course, our urologists do, and our department do targeted biopsy. Decision making is by urologists in most cases. Of course, we can disagree with it if I think it's not a real situation, but in most cases, decision to send patient to targeted biopsy to our department is by urologist, and in many cases they do after TRAS biopsy, negative TRAS biopsy they sending us. In some cases they evaluate, they look into our report, and if we recommended to do targeted biopsy, they follow up this recommendation. So we thank them because we have cooperate and we understand each other. So we do it fast. And my opinion, after successful targeted biopsy, systemic biopsy is not necessary, because many patients are very smart. They are going for follow-up. They are, if need, they go active surveillance. They don't disappear for many years. And if we some miss very small fortune of cancer, if patient coming to follow up to urologist, we found this lesion after years or two, we don't miss it. If when PSA growing up, patient come back to MRI and come back maybe to biopsy again.
So in conclusion, I'd like to say thank you for all the participants of that discussion. I think Multiparametric, biparametric MRI is the future for screening of prostate cancer, of significant prostate cancer. Also we have to do the targeted biopsies to find the most aggressive cancer and to find the best solution for the patient. Thank you very much.